This is, I don't know if you guys had a chance to read it. This is, was published in, was 2020, June 2020. You know, what has happened with diverticulitis is that it has changed. Every few years, things change in terms of recommendations. Even when I was a fellow training in colorectal surgery in 2004, we still had like this almost like a rule that someone that gets admitted with diverticulitis more than twice is a candidate for surgery. Or the other rule that anyone younger than 50 years old with a diverticulitis requiring antibiotics admission also should be considered to have elective surgery. But all over the years things have changed because there's more data about the how people do without surgery. And so things have changed somehow since then. I would say quite a bit in some areas. And there are now more specific recommendations for recommending surgery to people. There's still, a lot of has to do also with the way the patient is doing. Sometimes people can be just watched, even having a relatively complicated attack of diverticulitis, as long as clinically they are okay. So in this article, I think what struck me the most was the changes that I see. Patients coming to the hospital with microperforation. Micro meaning just some bubbles of air that around that you would say, oh, this guy's perforated, and maybe it's a candidate for surgery, even if he responds to antibiotics. That has changed. So microperforation is no longer considered a complicated attack of diverticulitis. And that's a relatively new change. A few years ago, we still recommended people coming with a little bit of, that were admitted with microperforation and follow up as an outpatient. We just say, you know what, you had an attack that was rather complicated with a little perforation. It's probably better to have surgery. But that has changed now. We don't longer recommend elective surgery. Patients recover well for that type of attack. The other interesting thing that I saw in this article is there's a condition that we call symptomatic uncomplicated diverticular disease. So what that is patients that have diverticulosis and develop like chronic symptoms that mimics intermittent diverticulitis. And those patients, you scan sometimes, and and honestly, the scans most of the time are normal. So diverticulosis with no diverticulitis. They sometimes come to the emergency room because those symptoms, and they just keep complaining of intermittent pain in the left lower quadrant. So that group of patients, we call it symptomatic uncomplicated diverticular disease patients that actually are going to benefit from surgery. So even though on paper everything is like, well, there's no diverticulitis, there's no inflammation, there's no complicated attack at all, but just the fact that the patient has diverticulosis and is having these symptoms, we offer surgery to those. We offer surgery. We actually have done a few over the last year or so since this article came out, offering surgery to those patients. We have done it, and actually they do remarkable. And that's the thing that changed, because in the past we would say, well, there's no diverticulitis, just, take antispasmodic medication and go from there. And by the way, most of the time the antispasmodic medication doesn't help. So, yeah, we don't offer immediately surgery to everyone like that. We try a little bit of different medications to diet, etc., to see if there is any response. But relatively often those patients fail that, and we just go ahead and do elective surgery.
Do you think the landscape will change in the future with these, micro-perf patients that are not toxic, that we start keeping them out of the hospital and you just treat them as an outpatient?
Well, the problem with that, I don't think those patients will ever go away in terms of requiring admission to the hospital. Because what can happen, most of the time I would say people will recover well, but there's a percentage of patients that keep getting worse. And, I don't know exactly the percentage. I would say at least 10% sometimes can potentially progress into something more significant, So I don't think we will keep those patients away from the hospital. I think the question is if we really need to admit patients that have just inflammation, sometimes those patients can be treated as an outpatient. In fact, there's a little bit of, there's another part of this article that I still kind of, we do it intermittently, not very often, in which actually they don't recommend antibiotics anymore for diverticulitis, And that's an area that I feel a little bit uneasy, about. But sometimes we do that, especially patients that are well known to have attacks here and there. Our first instructions usually is put yourself on a liquid diet, just don't eat anything, and you can take some analgesics and see what happens. If this continues progressing in a day or two, maybe we just go ahead and start antibiotics. But sometimes just by those patients putting themselves on that regimen, things improve rapidly.
And Dr. Casillas, do we not see that because we're in an acute care setting? Is that do primary care providers manage patients that way? Because I feel like anybody coming through our ER with diverticulitis, they get antibiotics.
Yeah, of course. And I think that probably has to do with that, I think we do see it here and there in an outpatient setting, patients that call. We don't scan everyone that just calls for, complaining of symptoms of diverticulitis, especially people that has had it before. We usually treat it, in that way. Depending on the situation, we start antibiotics proactively. I say most of the time we do antibiotics, but occasionally, we started just not giving antibiotics right away, just waiting and assessing the situation. Of course, fever and signs like that, of course, is a trigger to start antibiotics right away. But that's another area that it needs to be. I think we need a little more data about it. I think the article mentions some studies, but I think more data is needed to really see who can actually be managed like that. Of course you want to treat someone with uncomplicated attack, but how much is an uncomplicated attack? How much inflammation you can tolerate without prescribing antibiotics? So I think it's a judgment call.
For our perspective, some of the other general surgeons we work with that, taking diverticulitis patients on the wrong call, they're always like, well, he was young, having flopped with Casillas, they've had 2 attacks, having flopped with Casillas, and obviously some of that black and white rationale has been defunct in this article, that it's kind of case by case who gets an operation, electively. So who are the people that you do really want to see in the office, that have been inpatients, or do you want to see everybody who make that determination in the office?
No, I mean that. Yeah, I mean I think which your question. We would like to see all of those patients, because a lot of those some of those patients need a for their workup sometimes you want to make sure it's nothing else like a cancer. I know you there's a especially for complicated attacks of diverticulitis, we like to, if they cool down and go okay with medical management, we always like to do a colonoscopy because there's a good percentage of patients that may, not good percentage, but some of them have a chance of having a malignancy there, I haven't encountered a lot of those patients, but we recently had a case of a woman that certainly looked like diverticulitis. Actually, was complicated with a colovesical fistula, and the scans looked like diverticulitis. Everything looked, and ended up being a big cancer of the sigmoid colon, invading into the bladder. And so we encountered those cases. So you just keep that in mind. So we want to see some of those patients, and to assess case by case who if there's anything else associated with it. I have seen patients that young people that look like diverticulitis ended up being Crohn's disease at the end of the day, it's, I think I don't have a problem in terms of seeing those patients, but the bottom line is that they need, regardless of my office seeing them or not, I mean, I think all of those patients need a follow-up outpatient, to determine if they need any further workup or not. Yeah.
Dr. Casillas, this is Rebecca. I was just wondering, whenever you see these patients and assess them, how does the physical exam play into your decision? Like if they don't have a fever, is there a threshold on the physical exam that says, oh, okay, they're going to get antibiotics or not? Does that happen?
I think that's a great question, and I think that's what the people that the data that supports no antibiotics for diverticulitis, they base their criteria a lot on the clinical exam of the patient, if they look toxic or not, if there's any fever or not, and how bad obviously the pain is, and that's how the judgment comes in terms of antibiotics or not, or even sending people to the ED for a scan. So yes, well, that's important.
Is there any utility in getting a CEA when somebody with complicated diverticulitis, since I think the percentage rates were like 8 to 11% of an occult cancer? Or is that something you would do? And I didn't see, they didn't mention any of that.
Yeah, that's a very good question. I don't think we'll bring any immediate benefit of that. I think it's more important to do try to pursue a colonoscopy. The CA, by itself, I don't think it may clarify some, but sometimes can make it more confusing,
Well, it's usually elevated in smokers, right?
That's right. So, and then you get, it can make a little bit of bias in the way you look at things, but I feel that you just treat the diverticulitis, and and then we'll see where the patient goes. Yeah.
I mean, one thing I think, and Joey's trying to figure out, what can our group do to help these patients, help you. The things I read about the smoking, increasing the risk for diverticulitis, red meat intake, obesity. I mean, are there things that you would like to do for us to do in counseling, in their post-op instructions, to include that or to have some sort of order set?
Yeah, well, you guys are a huge help, to start that process. I think a lot of these patients need an education about risk factors for diverticulitis. And the conversation starts certainly in the hospital when they're inpatient. I usually like to tell them, this is a call for you, for a life change for you. I mean, smoking is a huge risk for having complicated attacks. Obesity, of course, diet, exercise, very important. That we saw that there's a very interesting statistic. I don't know if they came up with that number, but they say that if you exercise at least 2 hours per week, like the cumulative workout is at least 2 hours, you're a little bit better. Less likely to have diverticulitis, or the grams that they calculated for the red meat, consumption per week. So I think if you guys can establish a conversation with those patients that you see and you treat, I think is huge. Because regardless of where these patients go, either they resolve diverticulitis and that's the end of the story, or they eventually end up requiring surgery. I think just the call of the factors that risk this condition is huge. Yeah, absolutely.
One quick question.
Sorry, excuse me.
Oh, sorry.
Can you guys, oh, sorry.
Yeah, I just have one question. I noticed that in the article they're recommending getting a CRP to see, how elevated it is, because when it's elevated greater than 170, it's usually indicative of a worsening clinical picture. So I was just wondering if you were interested in us getting a CRP from now on, because we normally just kind of watch the white count, but not a CRP.
I think that would be helpful. I think we have instances of patients, not many, that get admitted and they just get worse and they need to be rushed into the OR. So I think it would be interesting to have those numbers up front,
Okay.
and maybe follow up numbers as they progress. And just to have, watch out, this guy is still not doing great and the CRP is going up. That you need to be very attentive of the progress of these patients. So to have a low threshold to go in.
Yeah.
The other interesting thing about this is the abscess. I think we have talked about that in the past. And those are the things that sometimes change, having an abscess that is about, when do we call IR to drain an abscess? The likelihood for patients to respond to antibiotics is less if the abscess is greater than 3 centimeters. So an abscess that is 3 centimeters or greater, we should be thinking about, we should be reviewing the CT scan with IR to see if they have a window to start draining those abscesses, Now, there is an interesting situation that sometimes happens that, some of those abscesses sometimes are intramucosal abscesses, so in the wall. And, those are, it's a different animal, it's more like the wall of the bowel that is, very swollen, and there may be a little bit of fluid or pus in there, but those abscesses usually we don't drain. Usually those respond really good to antibiotics, and doesn't make it like a more complicated attack, I think. Of course, it reflects inflammation, but it's not going to change, the decision it's not going to trigger a decision to ask IR to get it or not. So you have to make sure the abscess is extraluminal. And again, the 3 centimeter mark is what you want to see. If it's less than 3, very likely the antibiotic will take care of it. Now, do we rescan people? That's the other question that I find sometimes frequent. Do we rescan people that have like little abscesses? And I think the clinical judgment here is important. If they do well, I don't care. I don't think we should rescan people just to see if the abscess grew or not. As long as they're doing well clinically, we don't rescan. We just treat, continue antibiotics as an outpatient. Hopefully that's the end of the story. Of course, the numbers start getting worse, fever, etc., is when we rescan people.
One more question on rescans, because the article suggests a PO contrast doesn't really give you any extra benefit, and we routinely order the repeat CT scans with PO and IV. So I was just wondering if this would change your practice to not get any more PO or continue PO. Just wondering what your thought process was.
I think the IV contrast is enough, to be honest with you. Yes. The oral contrast becomes helpful if you're suspecting a fistula or an extra, you want to see extravasation of the contrast somewhere. I think IV, I agree, is more than enough. It's quicker, they don't have to drink the whole contrast. So I think IV should be probably just the standard, and the oral will be more the exception.
Okay. We'll reserve the PO for when there's suspicion of a fistula of some kind.
That's right.
Emily, did you have a question?
I just wanted to, I have a question. I just wanted to make a comment about kind of going back about like counseling. And I thought the podcast description of like telling a patient like why they need a low residue diet when like the literature says like, if you want to help with, prevent diverticulitis, you should eat a high fiber diet. And they described it as like a muscle strain and kind of like if you've been working out and you strain your muscle, you should kind of like take it easy so you don't prevent further damage. And then I thought that was kind of interesting in the acute setting, that kind of how to explain and counsel the patient as to like why a low residue diet is beneficial for them. I like that.
I agree, Emily.
Yeah. And and that's what some patients, and we need to clarify because some patients find it confusing on the discharge instructions about diet, and that's what make sure you guys explain to them that situation, Typically we recommend the low fiber diet for at least a couple of weeks, and then when we see them in the office as they are doing well, we switch them to a high fiber diet. And I think it's important that we give clarity to the patients how they're going to, when to change it, why, etc.
Just a thought, if you had specific instructions or things that you wanted patients to know when they leave the hospital before they come back and see you, or you or Megan or us, or, we've done it for other service lines, is put, like a Word document, a one-page thing together, and then putting the epic as a dot phrase, and everybody that goes home with diverticulitis all gets the same information.
Yeah, that's a good idea. Thank you. We'll probably put something together. Sort of what we did with the ERAS type of discharge and all. Yeah, that's a good idea because we see a lot. We admit a lot of people with diverticulitis, and I think having some clarity. I have seen patients here and there that the instructions were not clear and they're confused. I just saw a patient I think this morning that has been on a low fiber diet for almost a month because I couldn't see her before that month, and it's like, can I change now? It's like, oh, okay. I think probably you should have changed it a couple of weeks ago. So things like that will be helpful to have it clarified from the beginning. And having a written guidance would be helpful. We'll work on that. Thank you.
So many things we see: gallbladders, appies, bowel resections. Their course when they leave the hospital is pretty predictable. But I can say that, some of our diverticulitis patients, there's a lot that happens after they leave here that we don't see, and it's not always so straightforward when they leave. Like we'll see somebody for diverticulitis, and then I'll operate with you like a month later doing a colon resection, and you'll be saying how, they've been smoldering for the last 4 weeks and, have had a rocky course on the outside.
Yeah, and they do, a lot of these patients, sometimes it's hard to build them into an elective procedure, sometimes what we do is we give like a low dose of an antibiotic, like Flagyl. We keep them on 250 milligrams TID until sometimes the day of the surgery, especially with the people that have a more complicated attack, like fistulas, colovesical fistulas, or just chronic abscess cavity that was drained, and and just the patient just needs to have the surgery soon. But if you go too soon, how it looks. You guys know how it looks. The look can be awful there, So if we could, bridge the patient to wait for the surgery at least 6 weeks, I mean, things, are more feasible to manage inside. And that brings also the next thing of the article that I think it's been already for a little while, the recommendation to try to do an anastomosis even in the event of having to have urgent surgery, And I think that should probably be the best way to approach things. Of course, in the middle of the night, this is difficult to do a colorectal anastomosis. There are a lot of logistics around that. You guys know that. Firing the EA, the bowel prep, etc. But I think ideally, I mean, the patients that I have done, where we actually do an anastomosis in the acute setting, and we just divert. We do a loop ileostomy, to protect that anastomosis. But I feel overall the reversal becomes much easier because the reversal can be such a challenge on a lot of these patients. So especially the obese. So as long as there is no fecal peritonitis, that everything is just a mess, and you just have to do almost like a life-saving operation. I think if an anastomosis can be done, it would be helpful.
Is there many situations where you would do an urgent laparotomy and put them back together and not loop them like they were stating?
Honestly, it would take me a lot to do that. I mean, I don't think that's a prudent thing to do.
Right.
Personally, I haven't done it. I mean, I think I have a very low threshold to just get loop ileostomies, which are not minor. The loop ileostomies can be a problem too. People get, especially the elderly, can get dehydrated, and it's a problem. But it's better than have pelvic sepsis because of an anastomotic leak. And sometimes, I mean, it doesn't happen very often, but you look at the data of colostomy reversals is one of the most morbid operations, colorectal operations that people can have. It's the highest leak rate, and sometimes, some of those colostomies cannot be reversed. Just everything gets just terrible in the pelvis, a lot of fibrosis that happens, and sometimes it's just not possible to reverse people, or sometimes require a loop ileostomy. I've done it, that we reverse. Recently we have one guy that, he developed horrible scar tissue, and we did an anastomosis, and, there was a reversal from a colostomy, and I had to give him a loop ileostomy because the anastomosis was so bad there that, there was a little area of the anastomosis I didn't like. And I just say, I'm going to divert the guy because I don't want him to leak. And actually he did very well, better than I expected to. He stayed only like 2 days in the hospital, and now we are working him up to get the loop ileostomy reverse, which, as you guys know, that you guys have helped me in those reversals, is much easier to reverse a loop.
Do you know, like, what percentage of your patients that get a Hartman's that don't get reversed?
Very little. I mean, I can tell you that for diverticulitis, I mean, I think I only had 1 or 2 cases over the last, 14 years that I couldn't reverse. But it happens. Sometimes people cannot get reversed. So
one of the things the article also mentioned was to do the primary anastomosis, to have less complications, it should be done by a colorectal surgeon. So, which I doubt you want to be called in the middle of the night to be doing all these when you're not on call. But
don't ever text me, please.
Yeah, but it's kind of limited because you're our only person that really has that technical ability, I believe. Correct me if I'm wrong. I mean, do you think any of our other general surgeons would do Primary anastomosis and a ileostomy?
I think they would be more inclined to do a suture anastomosis. I have seen Wizalik doing it. I think it just comes to the point that if it happens, which usually is the time that it happens in the middle of the night. Honestly, even myself has a hard time creating an anastomosis, because it's just so, you just want to get it over, get the perforation done, and then, hopefully that will be it. So it's just not only the technicalities of doing the anastomosis, but also, the resources, etc., I'm not sure if all of you guys have fought an EA. I think most of you have, but sometimes it could be difficult, So I think that, and that's not only at Bacchus. I think it is everywhere, So for a surgeon, it's easier to just go do a Hartman's and that's it. However, for the patient, this could be complicated, more complicated to have a colostomy reverse and then a loopiostomy reverse. So I think if it happens in a reasonable time during the day, etc., anastomosis would be the best way to go.
Another thing that I don't know if our group could help with, I know where I used to work, our ostomy nurses and team would pre-mark patients.
Yeah.
In the article, it kind of mentioned, if you put an ostomy right where somebody has, an abdominal fold, it's going to have more issues in. But how?
It's crazy.
Yeah.
It's
so
crazy.
Do you pre-mark patients, or is that something that we can try and? I imagine it's not that difficult to have somebody sit up and. I've never been taught how to do it, but.
It's very easy. It's very easy. It's super easy. I can send you some information how to do it, but you know what? It would be very helpful that you guys can do it. You essentially just briefly you do that. You ask the patient to sit at the edge of the bed, and you look at the abdominal wall. All right, you ask them to sit straight. Patients tend to try to see what you're doing, so I just tell them, just don't look down, just sit as straight as possible. And then you just have to go on the side of where the rectus muscle goes. You just have to imagine where the rectus muscle goes, because that's the spot that you want in the rectus muscle. And then you see the right spot. You see the folds, and then you just mark it. That's it. In a reasonable spot. So obese people generally have to. Usually the best spot is above the umbilicus. That's where the best possible spot. But everyone else, in general, the ideal spot is just below the umbilicus, in a line just at the center of the rectus muscle. So it's actually quite straightforward. It takes literally a minute or less to mark it, and it's helpful. A lot of those patients come and they're sick and just want to get it over. And that's when the ostomy locations that are not optimal happen, because when they lie on the table flat, nobody has folds. So, you put it there, and guess what? The patient starts sitting and everything falls around that ostoma. And, most of those ostomas, I rarely reverse someone in less than 6 months from the event. So you're talking about having that colostomy for a good 6 months. So can you imagine having frequent leaks every day for 6 months? It's just miserable.
Yeah.
So yes, it would be great if you guys start doing that. It would be great.
We have 2 projects.
Yeah, and try to mark a couple of places. That's what ostomy nurses do. They do like a first spot, the ideal, then go to another one. Go on the right side too, in case he has a loop ileostomy instead of a colostomy. So mark 2 spots, one on the left, one on the right, and if there's a secondary spot that can be used in case of the primary spot doesn't work, it would be ideal. Sometimes there's not secondary spot; it has to be there. But sometimes giving some options is helpful. And you put number 1 and number 2. That's what we do all the time when we do elective marking.
Well, we can ask the ostomy nurse to even come and maybe do a little, like, in-service for us.
Oh, great. That's a good idea. Yeah, Lisa Orson. I'm not sure if she does it because she just changed positions, but I'm pretty sure she would be very happy to show you. Because at the end she struggles. See, we put the colostomy in the wrong spot. She's the one that has to try to figure out how to pouch that colostomy, and that can be a nightmare also for the nurse.
I mean, it seems like a little thing that could really improve the patient's quality of life. Yeah.
Yeah. Perfect.
Okay. By the way, are you aware of the new ostomy appliances that we are getting?
New ostomy appliance?
Yes, the new devices that we're going to start using.
Oh no, I haven't. I have not seen it.
So
What
it's,
is it?
I don't know, we had a couple samples, but basically the wafer part that goes on the skin now has kind of like a turtleneck that goes around the ostomy itself, and it's supposed to contain any output better than what we have currently. It's moldable. They come in 3 sizes. You can kind of mold it to the size of the ostomy. So we still haven't really used them, but I know they came by and gave us a little bit of the in-service. Well, it was a while ago. It was like 3 weeks ago or so. And they were going to start using them. So. Right.
Oh, good. I have to look at that. Yeah.
Dr. Casillas, the one thing, the very last, I think, topic they kind of talked was the laparoscopic lavage. I mean,
Yeah. I was never convinced that about how helpful it is. I ended up doing cases of surgeons that did it. Even Dr. Young, used to do it quite a bit.
They were horrible to go back and
And I honestly, my experience is that the scarring gets worse after laparoscopic lavage. When we do elective resection, I don't know why, but it's just I didn't have a lot of cases, in that situation. But the few that we did, it was like really nightmare to go in and try to do something.
Well, in the podcast, they talked about the one case where then all the ports like fistulized and had. I don't know if that was in the first podcast or the second podcast. It just seemed kind of like a
I think it sounded like an option to avoid colostomies. Giving someone a colostomy is an awful thing to do, but over the years, surgeons have tried a lot of things trying to avoid that, but sometimes it's just not possible. And honestly, in the beginning, it sounded like not a bad option. But I think most surgeons just are, disappointed about the results of this. A lot of those patients require surgery anyway, despite doing a lavage. So, I think that's pretty much what the article is saying too. That it's just not been as effective as we thought it may be. Yeah. So I think I would discourage people to do laparoscopic lavage. Yeah. I think the better option is if a patient needs to get to the OR, it's not too bad, there's not like a lot of contamination, resection and anastomosis should be the way to go with proximal diversion.
So really, if you're saying if they're stable enough where they can get a lavage as opposed to a Hartman, then they really, instead of the lavage, should be getting an anastomosis and a lumen.
Yeah, what I'm saying is that lavage, I think the results are not that great, and and really just buys maybe a few days, occasional weeks to the patients, but I think probably if a patient is going to develop a complication like perforation that needs surgery, I think it's better to just do elective resection, or urgent resection.
What's that?
Anybody else have anything?
Well, I think we covered pretty much everything.
Yeah.
I think it's just a few things that, obviously there are clear indications for divertical, for surgery,
It's usually not
like fistula, stricture, those are things that patients need to be reminded that may happen, and that's people that have these chronic attacks or diverticulitis or I tend to tell them, what happens with diverticulitis is that, you keep having attack after attack after attack, even if you kind of bounce back relatively okay after each attack. The problem is that with time, fistulas can happen or strictures, and that could be a serious problems with diverticulitis, as you guys know. So that's another reason too. Sometimes, those patients that keep having frequent relapses, we reminded them. And of course, when those complications happen, that's just an indication for surgery, fistulas, strictures. Young age is still not like you used to be like if you're younger than 50 and you got diverticulitis, you have to have surgery even after your first attack, and that has changed completely. We just go case by case basis. So I really don't think patients, yes, age is a determination. If the patient has frequent, or a complicated attack, there's no brainer about doing like recommending surgery. But someone that comes with just diverticulitis and gets better, obviously we want to make sure, maybe do a colonoscopy, etc. But not necessarily mean surgery anymore.
And is it useful for you to know how many episodes they've had? Instead of us just saying recurrent, saying, at least how many they have a year or how many attacks they've had in their lifetime?
I think it's important. I think, it's mostly what I want to see is if in the last year, if someone has many attacks, that's bad news. If someone comes here and say, well, every year I have a little attack and, you bounce back with no problems, I'm not going to recommend surgery, even if they had it for, the last few years, especially if they bounce back fine, if their colonoscopies, are unremarkable, if there's no symptoms. I said, I think it's probably better to just watch you, rather than put you through surgery. But again, if someone comes with, the last 3 months, has got 3 attacks, or the last 6 months, 3, 4 attacks, or it's a different story.
This was a great article, Dr. Casillas.
Oh, that's good.
Yeah.
I'm glad you liked it. I have, this journal. It's a very good journal, and they have actually recommendations for different things for colorectal surgery. So, so you guys can actually access this online. The American Society of Colorectal Surgeons website. They have like the clinical guidelines for different diseases, for cancer, for anorectal problems, etc. So if you guys have time and want to learn about something colorectal, that's the best site to go. All right.
Before we end, is there any points for us to, help move the needle or improve care from our team's perspective on these, types of patients moving forward?
Move the needle in what sense, Joey?
Just, are there things that you see that we could do to improve our care, whether it's your patients or somebody else's that you're seeing in the clinic?
Improve patient outcomes. So I think we've identified 2, like if we pre-mark patients, if they might need a stoma, and then also making some educational materials at discharge and kind of counseling.
And also talking about the risk factors for diverticulitis. That's actually huge. The smoke,
We need a
diet,
tobacco cessation program here.
tobacco cessation program, correct. Exercise. You tell them, you exercise at least 2 hours per week. So the cumulative time in a week, that's huge, for everything, not only for diverticulitis, for heart disease, for anything. So,
would you like me to reach out to Megan to try and help create that type of material and whoever else is wanting?
I didn't have a chance to send her the link of the Zoom, but she's listening attentively. She has ideas, yeah. Yeah, great.
Does she have anything she would like us, anything she thinks we could do to improve? Because, she sees these patients too, and just wondering if she had any inputs from a PA perspective, in the clinic.
She feels so strong about the information packet that we may provide, at the end. So,
Okay, well, one of us will be reaching out to her.
perfect,
Okay.
perfect, great. All right.
Thank you very much.
Thank you, Dr. Casillas. If everyone could stay on for 2 minutes afterwards, I'd appreciate it. So Emily and Rebecca, don't hang up, please.
Thank you so much,
Thanks,
guys.
Dr.
Sure,
Casillas.
have a good rest of the day.
Thanks.
Bye-bye.
Okay, you guys hear me? I guess I can stop recording.